Next question. What do you think of treating MS with chemotherapy?
Yes, so we've been doing that. It depends on what you call chemotherapy. Because I don't know if you remember mitoxantrone.
No, I don't.
So we used that maybe 10 years ago, and is a drug that people use for chemotherapy.
Right.
It was never licensed for use in MS, but until we had some better things, sometimes we ended up using it because we felt we had to do something. Yeah. And that was very much chemotherapy. That's really gone out, but I don't really know anyone using that as a standard therapy now, because we've got licensed therapies which are as good, if not better, and safer. But that's many years old. Yeah. And the other one that's come up recently, which is chemotherapy, which is licensed for MS treatment, is alemtuzumab, or Campath.
Oh. So
that's fairly recently licensed. Was developed for a leukemia, and then people in Cambridge used it in trials with MS patients, and it looked really quite good, though it does have some side effects. And so that is definitely what you would class as chemotherapy. Now, if we're classing chemotherapy on things that people would use for cancers,
right? Yeah.
Then we've got that one, and it's licensed, and we use it. And if we're linking this one to the stem cell transplant, then it's actually the same drug that people use for some of the stem cell transplant trials. So in stem cell transplants, what you need to do is either take out your stem cells, put them in a bag for a while, then get rid of all of your immune system, or at least most of it, and then give you your stem cells back, or people in the past tend to get somebody else's stem cells back. But the chemotherapy bit is getting rid of your immune system.
Yeah. No, I think it was the chemotherapy combined with the stem cell.
Absolutely. But the chemotherapy drugs that some people are using for getting rid of all that immune system are actually, one of them was alemtuzumab, which we've now got licensed for MS, which is why the first trial was a little odd, because some people were saying, well, maybe it wasn't the stem cells, maybe it was alemtuzumab, because we know that the alemtuzumab works on its own. Yeah. So it's a bit difficult to know. Yeah. So I suppose it's the same idea, is what you're trying to do with drugs in MS is sort out your immune system. Yeah. Now, you don't want to wipe them out if you're not going to replace them with something else, but you want to at least suppress them.
Right, yeah.
Whereas in stem cell transplants, what you want to do is wipe them out, or at least wipe them out a lot, not completely, but at least hit them hard, and then you can give back stem cells to regrow your immune system. So the idea is the same, it's just an amount, really. If you're not going to give something back to replace your immune system, you can't knock them out completely, you just got to sort of suppress them. Whereas in stem cell transplants, you want to knock them out quite a lot, so that then you can rebuild an immune system from the ones that you give back. Yeah. So in a way, it's the same idea, it's just extent. So we are using chemotherapy, drugs for cancer, on their own, but you can also use them to a greater extent, and then replace your immune system with either your stem cells or somebody else's, and it seems to be safer to give it your own stem cells back, because then you don't have problems with them not matching. It's like having a kidney transplant. Ideally you'd want one from your identical twin, so that you would totally match, but you can't get that mostly, so you have to take the nearest to match. But that's always more risky if you take it from somebody else. And it's the same idea in MS. If you get your own back, it's less risky than having somebody else's. The problem, of course, is that it was your immune system that went wrong in the first place. So if you get your own back, is that going to be ideal? Yeah. It's safer, but is it going to last forever? And that's the key at the moment. I think there's no doubt that the chemotherapy plus stem cell transplant works in relapsed and remitting disease, as was shown in the program by several trials that have come out. It works in relapsing remitting disease, where you need to suppress the immune system. What we don't know is how long it's going to last.
Right.
If it lasts for 40 years,
Yeah.
that'd be really good.
Yeah, absolutely.
If it lasts for 4 years, then you have to say, is it worth that risk?
Yeah.
Bearing in mind we've got other drugs now that work really quite well.
Yeah.
You have to take them every day.
Yeah.
But it's not quite. You've got to do a balancing act. And to be fair, the people doing the trials are very open about that. They say it clearly works, but the question is long term. How long for? And if it did work for 40 years, then this would really become something that maybe would be worth having.
Yeah, absolutely.
Or even 10 years.
Oh, yeah.
But you wouldn't probably want to go through it twice.
No,
because it's really nasty as a treatment with a mortality rate.
Yes.
And with young people who might do very well, it's difficult to know whether that's worth it or not. Which comes back to the future MS side of things, is if we can predict who's going to do well and who's going to do poorly, then the people who do well, you don't want to give them risky treatments.
No.
But we do want to perhaps, your risk-benefit for the people who do poorly is higher. But we've got to be able to predict that at the beginning, to say to some people, don't worry too much, we'll give you this, which is a milder drug with less risk, because you're going to do better, and you're going to do worse, therefore we're going to have to hit you hard with drugs like cancer drugs or like stem cell transplants, because we need to the risk of you getting disabled is greater. So it's quite difficult to work that out at the moment, but at least people are trying to work out who's going to do well, who's going to do poorly, and then we do now have a lot of options.
Yeah.
So it's just trying to work out who would benefit most from which option.
Yeah.
And it's not easy.
No, I can imagine.
But it's not easy for patients either, because you have to then say, okay, am I prepared to take a risk of 2% death, having my stem cell treatment when I'm 20 with a family? It's really difficult. Yeah. It's sort of, we have to work out risk benefits, and that's we're not used to. I mean, that's a financial job, isn't it? It's like, who buys shares, who deals in the stock market, who's a risk taker, who isn't.
Yeah.
And so it's not just how well people are; it's what they're prepared to take in terms of risk.
Yeah.
So it's complicated.
It's different.
But at least we have these options now.
Yeah.
It's better, but it's not easy.
Yeah.
For either patients or doctors trying to work out what the best route is.
Yeah.